Good morning, delegates. I'd like to welcome you to the third day of our National Conference 2013. I'm pleased to advise I've spoken with the Operations Manager and we have a quorum of at least half of the people who are here. Just as a courtesy to the speakers, if you'd attend to your mobile phones in case they were taken off silent or vibrate mode, and I'd also like to pass the message to you that an instruction has come from the hotel that everybody needs to ensure that they've checked out by the end of morning tea this morning, which is about 11 o'clock. Thank you. I'd like to pass to the chairman of the next policy session, Dr. Chung Soo Yong.
Thanks very much, Rod. Before I start, I'll just remind everyone that if you have questions, would you please use the website address that's up on the screen now. Hopefully most of you are familiar with the procedure now, but we'll get the questions from that feed and summarize and paraphrase them in question time at the end of the session. So today's session is entitled Health as a Postcode: Society's Ills and Individuals' Health. Doctors often concentrate on the individual physiological and genetic factors in illness. This is a natural outcome of the training and focus most of us have in administering individual care. Even when treating whole families or communities, most doctors look for the biological causes of disease. And there's certainly nothing wrong with this tendency. It's been very successful in getting the medical outcomes we all seek. But as an explanatory model for describing causes, predicting health outcomes, and identifying effective interventions, it doesn't tell the whole story. The reason for this is that the full range of factors that impinge on people's health reaches outside the individual level and into the social and collective domain. There's an increasing body of evidence that people's social circumstances are strong predictors of their health status and outcomes. The research on epigenetic factors and expression of behavioral phenotypes is helping to explain how environmental factors in utero and childhood can modify genetic risk in psychiatric illness, as one example. Another issue is the effect of the social environment in modifying access to services or opportunity to live healthy lifestyles. In recent years, the AMA has brought to attention the social determinants of disease in a myriad of settings. A clear and recent example of this was provided to this conference on Friday by John Brumby, who spoke about the newly released COAG healthcare outcomes measured in terms of socioeconomic status. You'll recall that the key findings of the COAG evaluation were that the rate of potentially preventable hospitalizations from chronic conditions was highest in areas of greatest socioeconomic disadvantage. And the greater the social disadvantage, the higher the rates of smoking and excess weight. And finally, if you lived in a socioeconomically disadvantaged area, the longer you had to wait for elective surgery. These findings and a great deal of other research are a clear indication that where you live can affect how healthily you live and how long you live. There is also increasing evidence that the interplay between social causes and individual outcomes can occur from a very early age and can consequently have lifelong impact. We're fortunate to have with us today three speakers who have all had solid first-hand experience of the impacts of social circumstances on health, and also what works to break or diminish the nexus between that social disadvantage and poor health. I'd like to begin by introducing Dr. Harold Klein, who will talk about how location can identify a constellation of factors that impact on health through the interplay of material, psychosocial, and behavioral pathways. Dr. Klein is Director of the Office for Youth, Office for Disability, and Office for Women's Affairs in Victoria. He's worked at senior levels in the Victorian government for over 10 years. He has a background in social theory, has taught politics at Monash University, and is also a fellow at the University of Melbourne. Dr. Klein will also talk about some of the outcomes of place-based interventions, such as the Victorian Neighbourhood Renewal Program. Would you please join me in welcoming Dr. Harold Klein?
Thank you very much, and thank you for inviting me to your conference. I think this is the very first time I've ever spoken at a conference on a Sunday morning. Seems cruel and unusual punishment, but thank you for being here. Here we go. I'm going to start my presentation today about the postcode characteristics of health with a picture of a public housing building that's a few blocks away from where I live in Melbourne. In 2001, the Victorian Burden of Disease study was undertaken to assess the comparative health status of Victorians. Remarkably, the study found that men living in this building and in the immediate neighbourhood were likely to die 7 to 8 years earlier than men who lived in an affluent suburb a short bus trip away. Similar disparities were evident for women, but not as severe. I've included in my slide some of the newspaper headlines that associated the release of the health data. The publication of the study caused a small storm as print and electronic media posted league ladders of health outcomes between neighbourhoods. Of course, the information led to a good deal of consternation for the people in poorer neighbourhoods that were being told they were sicker and would likely die sooner than other Victorians. We've grown used to hearing about dramatic disparities in health outcomes for Indigenous communities, especially in remote communities. To see similar numbers wherever there are significantly disadvantaged suburbs in Australia was a new kind of shock. Now, to some extent, all societies have inequalities in health between different groups and individuals as a consequence of immutable factors such as age, sex and genetic makeup. However, the reason people in particular neighbourhoods in Australia are sicker and dying sooner than others is not because of any natural condition. It's because of a preventable condition called social disadvantage. In my presentation today, I'll do three things. First, I'll summarise the research that shows the correlation between socioeconomic inequality, locational disadvantage and the burden of disease. Secondly, I'll assess the policy and practice implications of this association, an association that makes a very compelling case for a social model of health. And finally, I present you the Neighbourhood Renewal Initiative, an example of a social model of health focused on addressing the locational drivers of health inequality. And then my colleague Mark Kennedy will talk a little bit more about how one of those neighbourhood renewal projects in particular worked. So let me start with the issue of the correlation between burden of disease and socioeconomic status. It is an association that is well documented and is consistent no matter how we define or measure the terms. Everywhere, the rich live longer and healthier lives than the poor. As the eminent epidemiologist Len Syme argues, being poor means you are more likely to contract disease in virtually all body systems, including the digestive, respiratory, circulatory, nervous, blood and endocrine systems. It also involves higher rates of mortality for most malignancies, congenital anomalies, infections and parasitic diseases, accidents, poisoning and violence, perinatal mortality, diabetes and musculoskeletal impairments. Australian researchers have shown that socioeconomic differences in health are evident for both females and males at every stage of the life course. Poorer people experience poorer psychosocial health, have a worse risk factor profile, and are more likely to engage in behaviours that are detrimental to long-term health and well-being, and are less likely to use preventive health services or detect disease at an asymptomatic stage. One of the effects of the trend over the last 3 decades towards a less equal society in Australia has been an increasing concentration of disadvantage in particular neighbourhoods. Mapping the spatial distribution of health status across Victoria using the burden of disease study gives a very clear picture of the correlation between the locations of high morbidity and mortality and geographical areas of socioeconomic disadvantage. As you can see from the slide, poor health outcomes, in this case mortality, are concentrated in Melbourne's disadvantaged northwestern suburbs and poorer rural and regional communities. This research is replicated in many other studies in Australia and overseas. It is well summarised in the UK white paper, Saving Lives, which argues that over recent years, it is the health and well-being of people living in the most run-down communities which has suffered the most. Poverty, low wages and occupational stress, unemployment, poor access to transport and shops, crime and disorder, and a lack of recreational facilities all have an impact on people's health. Drilling down to areas smaller than a postcode, there is growing evidence of a super concentration of social disadvantage in particular neighbourhoods. When I was developing the neighbourhood renewal strategy for the Victorian Government in 2002, I commissioned the Australian Institute of Primary Care to research the most intense geographical pockets of disadvantage in the state. The research identified neighbourhoods where residents were 83% more likely to be in receipt of unemployment benefits than the state average. They were 63% more likely to hold a disability support pension. They were 45% more likely to be healthcare card holders. Educational standards were well below average, with 53% less people completing Year 12. Crime ran at 158% over the state average, with the neighbourhood in my first slide registering an astronomical 450% higher crime rate. Child protection notifications were 129% over the average, and there were 148% more single-parent families, with one area registering 52% of all households as single-parent and 33% of the population under 14 years of age. I think you'll agree that these are astonishing numbers and they really do offend the egalitarian ethos of Australia. But how do these forms of disadvantage cause poorer people to become sicker and die sooner than other Australians? We know that social disadvantage increases susceptibility to morbidity and mortality in at least three ways: behavioural, psychosocial and material. At a behavioural level, being poor increases propensity to high-risk activities like smoking, excessive alcohol consumption, fatty diets and sedentary lifestyles. At a material level, disadvantage impacts on health through both absolute and relative deprivation. Being poor increases exposure to unhealthy environments, excessive physical wear and tear on the body, and it makes it harder to access services. It's been argued by Richard Wilkinson and others that it is not only the fact of poverty, but also the experience of relative inequality anywhere along the income gradient that has a negative health effect. At a psychosocial level, those that are subjected to it experience disadvantage not only as a lack of resources, but also as a lack of opportunity compared to others who have better lives and better prospects for social and personal progress. Epidemiologists have argued that being disadvantaged in this sense increases susceptibility to stress, depression and anxiety, which in turn increases the likelihood of a variety of illnesses. Given this causal relationship between society's ills and individuals' health, it should be clear that changing population health outcomes is premised on changing the social determinants of health. In the case of disadvantaged neighbourhoods, this requires a concerted attack on the dynamics of locational disadvantage. To do this effectively, we need to understand how locational disadvantage works. In short, we can say that the pathology of place is a toxic combination or interplay between the characteristics of the residents in the community, such as unemployment, education levels, drug and alcohol use, and over and above this, the effects of the social environmental context in which they exist, the so-called place effects or neighbourhood effects, such as weak social networks, poor role models, and a relative lack of opportunity. Tony Vinson describes the phenomenon as one where separate forms of deprivation work together to constitute a web of disadvantage, a system of constraints on the life opportunities of people residing in some communities. So what are the policy and practice implications of the causal nexus between socioeconomic status, burden of disease and disadvantaged places? The traditional policy response to health inequality is to make existing health services more accessible to population groups most in need. This can involve redistributing services towards socially disadvantaged locations, targeting high-risk groups, and improving the coordination of care for those with the most complex needs. This kind of biomedical strategy is a necessary but insufficient policy response to health inequality. While health services have an important role in medical cure, treatment and psychosocial support, they cannot substantially influence the upstream social and economic conditions that make people ill in the first place. Shifting the focus of effort from biomedical to behavioural strategies to prevent health inequalities is not the solution either. We know that while health promotion campaigns targeting behavioural risk factors such as diet, exercise and smoking have been successful in changing the lifestyles of more affluent and educated social groups, they have not substantially transformed risk patterns amongst the poor. We also know that fragmented approaches that address one of the social determinants of health in isolation from other determinants with which it combines will not work, nor do approaches that are imposed on communities without engaging them to be empowered to be part of the solution. If we're serious about tackling health inequalities, we need to develop interventions that transform the structural drivers of inequality, that integrate a variety of responses across many government portfolios and non-government sectors, and that directly involve the subjects of health inequality in their formulation and implementation. The essence of this approach is captured well in the World Health Organisation's Social Determinants of Health, the solid facts, in the proposition that improving population health outcomes involves reducing levels of educational failure, reducing insecurity and unemployment, and improving housing standards. Societies that enable all citizens to play a full and useful role in the social, economic and cultural life of their society will be healthier than those where people face insecurity, exclusion and deprivation. Neighbourhood renewal directly applies this prescription to regenerating disadvantaged communities. Neighbourhood renewal is a whole-of-government and place-based intervention to narrow the gap between the most disadvantaged communities in Victoria and the rest of the state. Over the last 10 years or so, 21 metropolitan and regional projects have been funded for 8 years, and each of the projects sets out to deliver a 6-point plan of action to increase pride and participation, to enhance housing and the local environment, very importantly, to lift employment, training and education and expand declining local economies, to improve personal safety, reduce crime, promote health and well-being, and to improve government responsiveness. These actions reflect an important paradigm shift from treating symptoms to transforming communities by targeting the sources of inequality, from fragmented programmatic reactions to integrated and joined-up solutions that respond to the complex interdependence of the determinants of health, and from paternalistic service provision to social investment and citizen participation that devolves powers to communities to take greater responsibility for their own futures. Neighbourhood renewal combines a top-down commitment from government to real social investment with a bottom-up engagement of communities in driving the process. Let me illustrate these three elements, starting with the way we generated a whole-of-government investment in disadvantaged areas. We essentially brokered an agreement between all state government departments and participating local governments to better coordinate their efforts within disadvantaged communities, to support the implementation of that community's action plans, to work in a way that was more responsive to those communities, and most importantly, well, maybe not most importantly, but as importantly, to really start to target additional resources to areas that had previously been significantly under-resourced. What this meant in practical terms was a real investment in housing in disadvantaged areas. That first couple of slide pictures that you can see there are in that same public housing building that was in my first slide, and it shows the sort of condition people were living in up until maybe 5-10 years ago, when we undertook a wholesale redevelopment and refurbishment of those buildings. There was a significant investment in social infrastructure to allow places for people to come together in their local communities to plan for change. There was a significant investment in parks and the amenity of local areas. Where there were high levels of concentration of public housing, there was an investment in redevelopments to create mixed tenure communities. This is again another picture of that high-rise estate with some of the more recent development that has occurred around the estate and in the estate. More than 9,000 jobs were created for long-term unemployed residents through the introduction of intermediate labour market programs, through the nurturing and funding of social enterprises. There was an important focus on improving the quality of schools and education, a big investment in the regeneration of what were often very run-down schools, and also a real investment in trying to break down the digital divide. New policing models were introduced, forms of community policing that were proactive rather than reactive, and a strong investment in actually designing out crime from local communities by turning them from no-go zones scarred by graffiti and vandalism and syringes to creating places where people wanted to actually participate and interact and undertake economic activities. So the second element of the strategy is all about participatory community governance. Taking the participants' frame of reference into consideration and sharing power and control leads to improved health outcomes and changes the policy frame from one where disadvantaged people are seen as the problem to one where they are part of the solution. Each neighbourhood renewal project established a form of community governance that involved at least 50% local residents, as well as representatives from local businesses, schools, police, the community sector organisations and government. Mark will describe to you in his presentation how this kind of arrangement has worked extremely well in the Corio-Norlane Development Advisory Board. A critical task of local communities and boards was the creation of a community action plan based on the 6 objectives of neighbourhood renewal, which guided and prioritised investment and action. Again, Mark may describe the action plan that his community development, which was impressive enough to actually have the Corio-Norlane area nominated as a World Health Organization Healthy City. This is all very consistent with the World Health Organization definition of community participation as a process by which people are enabled to become actively and genuinely involved in defining the issues of concern to them, in making decisions about factors that affect their lives, in formulating and implementing policies, in planning, developing and delivering services, and in taking actions to achieve change. Oops. Finally, the connection between top-down whole-of-government investment and bottom-up community governance doesn't happen spontaneously. Indeed, most of our institutional arrangements in government militate against it happening effectively. The element that really connected top-down investment with bottom-up community engagement in neighbourhood renewal was the establishment of place management teams. These teams incorporated a place manager, a community development worker and an employment and learning coordinator. And rather than managing any specific government program, these teams were responsible for empowering local citizens, coordinating area planning, brokering partnerships, allocating resources and bringing new resources into the area. So let me conclude my presentation by showcasing the headline results from the comprehensive evaluation of neighbourhood renewal that was undertaken in 2009. The evaluation assessed progress against a number of indicators relating to all 6 of the initiative's objectives. The outcomes, I think, were a strong vindication of the approach that was taken. As you can see from the slide, 80% of evaluation indicators showed improvement or the arresting of further decline. 62% of evaluation indicators showed the gap between neighbourhood renewal areas and the rest of the state had been narrowed. And 76% of evaluation indicators showed the decline had been halted or the gap narrowed with similar socioeconomic groups in other parts of Victoria. Although these evaluation results show neighbourhood renewal is on the right track, of course there's still a very long way to go. To use a medical metaphor for the neighbourhood renewal intervention, the dose may not have been strong enough and the treatment may have stopped before the patient was fully cured, but I think the evidence is showing that the prescription was right. So I'd now like to hand over to Mark, who has written out probably more prescriptions than most in disadvantaged communities. Mark's been a great leader in the renewal of North Geelong and is a great advocate and champion for the social model of health. Thank you.
Thank you, Dr. Klein. I'll now introduce Dr. Mark Kennedy. He may already be well known to many of you. Dr. Kennedy is an AMA member and a GP from Victoria who's been instrumental in establishing neighbourhood renewal initiatives in Victoria. Dr. Kennedy will talk about his hands-on experience in neighbourhood renewal. Please welcome Dr. Kennedy.
Thank you for the opportunity to present at the conference today. What I'd like to talk about in my presentation today is just a little bit about the neighbourhood renewal program as it worked in Corio-Norlane, and then its transition across to the Corio-Norlane Development Advisory Board, and then try to present you with a little bit of a flavour of how medical practice can be different in a lower socio-economic area, and then finally address the challenge that Harold has left us with about how we as doctors can contribute towards addressing health inequity and inequality. Corio-Norlane was one of many of the neighbourhood renewal areas identified by the previous state government. We did a presentation to the Treasurer at one stage at the time, and he said that it was 2.5 times larger in terms of population than the next largest neighbourhood renewal area in the state. Harold would probably know if that's true or not, but that's what John Lenders said. And when it started off with a community reference committee that was made up of elected members of federal and state government with electorates in the area, 2 local councillors, and then senior government department managers, CEOs and senior managers from council and from the not-for-profit sector, from business, local police and the local primary and secondary school. And we had 50% community members on the committee, and they all tended to represent community centres and other community groups and organisations within the Corio-Norlane area. For the first 12 months, the chair of the committee was the Mayor of Geelong, and then the state lower house member was the chair until the change of government, and I've been chairing it since the last state election. In June 2008, just before the neighbourhood renewal program was due to finish, we recognised that what we had achieved with this great group of people that was able to meet every 2 months and work towards addressing a lot of the inequities and resource lack in our community was something we didn't want to disappear at the end of the funded program. And so we went about creating a slightly different group that would be able to continue on after the program finished. And so we changed the name, but otherwise we stayed with the same members. And since that time, we've been invited to give evidence to 2 parliamentary inquiries looking at different aspects of disadvantage. We are a full member of the World Health Organization Healthy Cities Alliance, one of only 8 in Australia, and we've spoken by invitation at their conference in Seoul in 2010. We've served as the Community Advisory Committee for a number of programs that have been working in the area, from the new $87 million water treatment complex to education regeneration program and many others. And we're continually now invited to contribute to discussion forums and community structure plans, advisory groups, and strategic planning around the whole community. One of our successes was in starting the process to get fluoridation into the water supply of Geelong some 30 years after it was in the Melbourne water supply. We've just recently gone about working out what our purpose in 2013 and beyond will be, and we've worked on 4 separate main areas. One is providing the opportunity for integrated planning, so that the different agencies working within the community are able to come to our board meetings by invitation or as members to get local input and advice, so that they're not duplicating services that are already available, they're not working across other projects that are in operation, and that they are responsive to local needs. We provide a local voice in the decision making that affects the area, whether it's been about transport or the structure plan that the City of Greater Geelong has recently established for our area. We take a senior role in advocacy, influence and leadership and advice, and we serve as a two-way knowledge exchange where local stakeholders and the community, various levels of government and community organisations are all able to exchange information about what they're doing and what their needs are. I just thought I'd touch on some of the particular areas in our community that are a challenge for us. Our Year 12 completion rates in Corio Lane are under 25%. Unemployment rates are under 20%, but joblessness rates are over 50%. In fact, one recent figure I saw was 58%. Our overweight and obesity rates are 20% higher than the more advantaged parts of Geelong. Smoking rates are 2.7 times higher. And our patients are often unable to access a range of health care because of the cost of care, whether that be consultations with GPs or specialists, allied health, or counselling services, whether it be medications that otherwise they would be taking, or whether it be even investigations sometimes. Health literacy, we know that health literacy across Australia is poor, and I'll talk about that a little bit later in a few moments. But for many of our patients, where the average reading level is down at Year 5 to 6, the information that they receive from other parts of our health service is inaccessible to them, and GPs are often serving a translation role, not just in terms of the information that they've been given in the hospitals or the written information that they're getting from Centrelink and other services. Chronic stress levels are from financial situation and from a lot of the other social determinants are chronically high, and the people with severe psychological issues much higher than in middle class society. Health insurance rates are very low. I should just point out I work in 3 practices, 2 in Corio and majority owned all of them, but I've also got a practice in middle class Lara, which I've had with my wife for 20 years. And when I'm seeing patients in my middle class practice, I always ask whether they've got private health insurance, because my options in terms of managing them are very different if they do. And many of the patients have private health insurance. In Corio, over 85% of our patients are on welfare. Almost none of our patients have access to private health insurance, and so they're all reliant very much on the public health system, both community-based and hospital-based. And transport's a major problem. Some parts of our community, 40% of households don't have access to a car, and our public transport is essentially bus and taxi, and again that's inaccessible for many of our patients for the destinations they need to go to, and it creates issues in terms of accessing care, accessing nutritious food, which again I'll mention about, and the exercise activities that they have available to them. Obesity rates I mentioned. Diabetes, the prevalence of diabetes in Cooroa and Norlane is 60% higher than the national average. And one example of how we address that, I'll talk about in a few moments, but I just want to make the point that sometimes we assume that the patients living in these areas are not interested in their healthcare because they're not following our advice. And you know, the more I actually take the time to ask my patients why they're not following our advice, the more I realise our preconceptions are often misplaced. Smoking rates obviously lead to much more coronary heart disease and chronic obstructive pulmonary disease than we see elsewhere. Depression rates, as I've mentioned. And we have, the other issue we have is it's difficult to get health workforce out into the community. There's a stigma attached with working in lower socioeconomic areas, and clearly the income opportunities are not as great. And so we, up until recently, we've struggled to get doctors there. We're a major medical student and registrar teaching practice, and it's a 15-doctor practice, and we now have five registrars across our 2 sites. And many of them are actually opting to stay on once they've actually been working in the area and seen the opportunities to practice good medicine. Now, I'm just going to go through a few areas in brief where I can talk about you know, some of the specific issues that may be different working in Cooroa and Norlane than in a lot of other parts of Australia. And so I'll move on to the first one, which is lifestyle advice. And we had a study done, funded by the state government a few years ago, looking at food security or access to good, healthy food. Cooroa and Norlane was one of the sites they were studying, and another one was in Werribee, I think. And one of the things they identified is the availability of fresh fruit and vegetables in Cooroa and Norlane was far less. The number of venues selling it was far less than in comparable suburbs. But also the cost of fresh fruit and vegetables in the supermarkets in Cooroa and Norlane were more expensive than in the same supermarkets in middle-class parts of Geelong, 20 minutes further away from where the market gardens and the fruit wholesalers were based in Melbourne. So access to services, to healthy diet, even for patients that understand what they should be looking for, is more difficult, especially when they have transport barriers. The knowledge is often lacking. We assume everybody now knows what a healthy diet is, but the literacy level of the community is such that they don't always get the full message. And I can remember a number of times when I've had patients keep a diary, a food diary, over a week or two, and we've sat down and tried to look at what they're eating and where we might be able to make some improvements. And I've been surprised at what they think is quite healthy. I remember one mother being quite surprised that a Big Mac wasn't healthy for her child because she had understood a bit about the different food groups, and she thought it had some bread and it had fruit and it had vegetables and it had meat and it had 3 of the groups, and surely that was the sort of thing she was supposed to be doing. And you know, she wasn't trying to be humorous. She was genuinely surprised when I said, you know, talked about the sugar content and all the other issues associated with that. And then the cost of, in terms of exercise, we know from lots of studies and a big study done in Ballarat University that walking is not a preferred exercise modality for everyone, and particularly not for men. It's terrific for people that enjoy it, but if we're telling our male patients to exercise more, many of them won't be inspired by walking in the same way as many of our female patients. But the opportunities for alternative exercise within an area like Cooroa and Norlane are very limited for lots of reasons. I mean, services are actually not available. We've got one gym, that's it. There's the access to other sporting clubs, access to equipment is expensive, and transport's a barrier for a lot of those things as well. And then there's safety issues, and it's all very well for me to tell my patients to walk in the morning or in the evening, but there are a lot of streets and parks in Cooroa and Norlane that I certainly wouldn't feel safe to to walk in the dark, and when we were having this discussion at one of our Development Advisory Board meetings recently, the police representative on the board made the comment that when he's in civilian clothes, there's plenty of places in Coronal Lane that he doesn't feel comfortable walking around as well. So the lifestyle advice we give may be not followed by our patients, not because they don't care about it, but because there are a lot more barriers to engaging in healthy lifestyle in an area like Coronal Lane. I talked about the prevalence of diabetes, and it's 60% higher than the national average. And for our diabetic patients, when we make the diagnosis, we explain to them about their need to access a whole raft of services: the GP, the diabetes educator, the dietitian, a podiatrist, pharmacist, obviously optometrist. For many of our patients, again, their organisational skills, their planning skills, their access to transport, all of those things make it a very challenging task to access all of these different services across a number of different venues at different times, different days. And for a long time, we thought the reason our patients weren't following through with our referrals was because they just weren't really engaging in, in their diabetes management. And when we actually started to try to uncover the reasons, we discovered that transport was probably, and coordination of those services was probably a bigger problem than anything else. And so we worked with the Barwon Health, our local health authority, tried a virtual model of addressing that, where we could coordinate appointments between the nearby community health centre and the medical clinic to try to get them on the same day, and that didn't work. And then 4 or 5 years ago, we developed a standalone building next to the medical clinic where Barwon Health allied health workers come down and consult out of those rooms on a part-time basis, so patients are able to access our GPs, our own diabetes educator, podiatrists and dietitians from Barwon Health, and soon an endocrinologist. And so they can get multiple visits done in the one day and remove many of those organisational barriers that previously were there. And we've already done some data analysis on the first few years and found not only reductions in the proportion of patients that are overweight and obese that are attending our diabetes clinic, but reductions in blood pressure and haemoglobin A1C, and more patients at target for haemoglobin A1C. We are now able to very easily get patients onto insulin using the different members of the team, and I think now the 4th highest postcode prescribing insulin in Australia. Given that the rates of type 2 diabetes patients in Australia on insulin are far below what they should be in terms of getting our diabetic patients to control, then it's one area we're probably not as far behind in as most other things. We've certainly got a lot more of our patients now involved in participating in team-based care, and some qualitative studies we've done have shown that they all, on the whole, enjoy improved self-confidence and self-efficacy. And one of the things that they identified, which we hadn't considered, was that normally when they're seeing lots of different people in different places, they get very confused by the conflicting advice they're given around diet and other diabetes management. And being all in the one place and having the one database has enabled us to provide a consistent message. We give one set of patient education materials, and for lower literate patients that's particularly important. Pap smear rates. We have state and national data presented, the Pap smear registry reporting data that consistently shows the Pap smear rates in the lower socioeconomic quintile to be much lower than the average, or than that in the highest socioeconomic quintile, and that's certainly been a problem in Coronal Lane. And we've struggled to get our Pap smear rates over 50%. We've done an enormous number of activities to do that. We run Pap smear clinics and evenings on weekends. We have nurses trained up. We have female doctors running Pap smear clinics all the time. We do it opportunistically, but we still struggle to get it much above 50%. whereas in my middle class practice, with just a reminder letter every 2 years, we consistently get over 2/3. And the problem is that the safe sex behaviour in Crianor Lane makes the need for pap smears even more of an issue. And it's not that patients don't care, which is something, again, that we may well assume, but there was an interesting experience in Colac, another neighbourhood that was targeted for the neighbourhood renewal, where they ran some focus groups on young women that weren't getting pap smears. And as part of those focus groups, they realised the women didn't really understand the need for getting pap smears, and they didn't realise how they could get them from female GPs and nurses in the Colac area. So the rates actually increased as a result of the focus groups getting the message to the patients in a way that our other education campaigns hadn't managed to do. There are other, so I've talked about that. One of the interesting things I read when we were looking at different ways of trying to improve our pap smear uptake was that one of the most effective strategies that had been adopted for improving pap smear rates in lower socioeconomic areas in the UK, whether it was intentionally or accidental, I'm not sure, but was when they ran a series of episodes with a storyline of somebody who got cancer of the cervix on one of the UK soapies. So my point is that, you know, we have the same sort of problems across all stratas of society, but maybe the causes and barriers to, you know, following good medical intervention are different, and maybe we can't just have one way of trying to educate all the different members of our community as to why they need to do the things that we're trying to get them to do. Thought I'd touch on health literacy. There is health literacy. There is now some Australian data from the Adult Literacy and Life Skills Survey, and using international benchmarks, only 41% of adult Australians have adequate health literacy. But the problem in our community is that if you break that down and look at unemployed or the elderly or those with Year 10 or lower educational attainment, the rates are down much lower again. And most people with poor health literacy aren't detected by anyone in the health system. We can't rely on somebody's verbal fluency to indicate how well they can understand written material we're giving them. In one study, one American study, only 20% of payers at less than grade 3 level of literacy were actually identified by their doctors. And that's not because we're not necessarily good at picking it. I mean, that's probably part of it, but also that many of our patients are ashamed and hide the problem from us. And so, you know, we need to be aware of it in the information we provide, rather than assuming everybody has a level of the level of health literacy that our own children enjoy. And there are lots of consequences of poor health literacy. There's lots of data, and I've just picked out a very small sample. Smoking rates are higher, smoking rates in pregnancy are higher, breastfeeding rates are lower. Children's care, so if the mother's health literacy... Okay, all right. I'll just let you have a look at that and move through. Oral health, another really major problem in lower socioeconomic areas. In 2003, the Senate Select Committee identified oral health as the most socio-economically linked of all health conditions, and ACOS has identified 40% of adult Australians not getting dental treatment. And for people without access to private health insurance and without access to the money to pay for private health insurance, to pay for dental care, getting your teeth out is cheaper than fixing them. And as you can see there, the rate of people that have had all their teeth extracted is 25% of healthcare card holders, as opposed to 10% of the adult Australian population. And I'm not going to run through this in detail, but it's not just about pain and discomfort. I mean, it's about employability, it's about self-esteem, it's about quality of life, increased GP visits for antibiotics for abscesses because they've got to be waiting for months to get access to public dental care. I'm not going to talk about this in a lot of detail, but just to say that that in Europe in 2006, a health in all policies concept originated. WHO has been advocating this, and now it's being implemented by all countries of the European Union. And it's about recognising the health impacts of every piece of legislation that's passed. And that if we're going to improve all of these social determinants, it has to be done across all policies. And South Australia in 2008 adopted that same health in all policies many years after Harold and his group identified the need to do the same thing in Victoria, but it's now part of their government policy. What can we do? We can contribute to policy at a national, state and local level. We can contribute to the debate within our own communities. We can actually get into the schools and contribute around their health and wellbeing agenda, given that the obesity incidence and a lot of the risk-taking behaviour starts in the school years, and we can lobby with and within and advocate for our communities. The American Medical Association has a website that's got a lot of supportive materials to help doctors who want to be more advocates for their local communities. And you know, we should remember that we have the credibility and the influence and the ability to speak for our patients. And I'm just going to finish with a quote. You've probably all heard about the quote when it comes to public health. It's not just about more ambulances at the bottom of the cliff. What we should be doing is building fences at the top of the cliff to stop people falling over. But I was surprised to see that this concept actually first came from a poem written in 1895, and I've just pulled out one verse from that. But it's not a new message. The message has been there for a long time, but we're never really going to achieve the great outcomes, improved health outcomes, if all we're doing is treating people at the end stage rather than affecting the determinants of poor health. Thank you.
Our final speaker is going to allude to some of the comments I made before about epigenetic research and the importance now of the environment in modifying our genetic risk. Professor Victor Nosser is a leading community paediatrician with nearly 30 years' experience in implementing community-based programs to enhance the health and development of children and young people. Professor Nosser was the Foundation Associate Dean, establishing the School of Medicine at the University of Notre Dame in Sydney, and he has developed and led the implementation of a number of high-quality early development programs and initiatives throughout Australia, including the Australian Nurse Family Partnership Program. Professor Nosser will speak on the ways that social factors and circumstances translate into physical and neurological conditions through childhood development, and some of the key interventions that the evidence shows are worth investing. Please welcome Professor Nosser.
Thank you very much. Thanks to the AMA for inviting me, and also pay my acknowledgements to the traditional owners of the land here, the Gadigal people. What I want to talk to, and in a sense I've been told to make it 25 minutes rather than 35 minutes, is to briefly jog you through a whole range of science. It's in a sense moving back from, yeah, poor people need better services and we need to improve their health, to understand as a doctor, how do social determinants exert their effects? How do they actually go from streets and shops into your physiology? And the assumption that it's just simply the way that people behave or what they do with their lives is not based in science. Because if we look at the science, we can actually find places to intervene much more effectively. And this resonates with a number of points raised in the last 2 days of this conference, that there's a lot of this prevention stuff that doesn't really seem to bite. So alcohol, gambling, there's a whole obesity. We keep telling people, but they just keep doing the wrong things. And we need to understand why we're not getting the traction that we need. Social determinants, you're hearing lots about it. And I guess I won't go on about that because you're hearing it in government reports and in college reports. In fact, it's in the conference here. Most often, it's a code for poor people's health. You know, there's the rest of us and there's poor people. Well, unfortunately, that's not what social determinants is about. What it's about is your health, your patient's health, my health. It's actually the principles that determinant of our health. Not my decisions this morning about how much calories I ate, not the germs I'm exposed to, but where I was born, the kind of conditions I grew up with, where you live. These are actually the primary drivers of your health and my health, your patient's health. And unless we actually understand that, we can't understand why prescriptions about eat better, exercise more don't make any difference, because they don't on the studies that we do. There is a clear and consistent relationship. The richer, the more affluent, the more privileged you are, the healthier you are. The poorer you are, the less advantaged you are, the poorer your health. And it's a gradient. You're going to live on average longer than the people who work for you. Fair or unfair, that's what's going to happen. You're going to live on average less than the people for whom you work. There's this lovely study, and I didn't include it on the slides, about Oscar winners. The people who win more Oscars on average live longer than the people who have one Oscar, live on average longer than the people who have one nomination, live on average longer than the people who've never had a nomination. Now, you cannot tell me that an Oscar in any way correlates with genetic advantage. But it's true. What happens is, in health, we increase the health hazard that people have to confront by adding to that gradient, the social forces that make that gradient bigger and bigger. But what we focus on is all the action on the individual. You know, yes, you live in a bad suburb. Yes, you've had a terrible childhood. Yes, you've survived all these things. But you have to get better with your life about eat better, exercise more. And surprise, surprise, it doesn't have much traction when you measure efficacy studies. These things are all well intended, but don't work. This is work done by Marmot, so Michael Marmot's the guy who did a lot of the gradient work, who chaired the WHO Social Determinants Committee. And the reason I include this slide is because he's got a lot of work, which, in fact, if you ever go to have a look at his reports, it's very well worthwhile to read the science about the gradient of health. In this seminal study, they basically showed that access to healthcare in England did not reduce the gradient, not in any appreciable amount. Because in England, people got their CAGs, they got their exercise studies, they got all the drugs they needed, and they still had the gradient in health. So this is not an argument for not making fairer health service distribution, and having spent 12 years as the head of child health in southwest Sydney, I still argue for resource redistribution to the people who need it. But on top of that, on top of your fairness, you need to do something which addresses the social gradient. Does any of this matter? Well, yes, it does. This is from a National Bureau of Economics Research study in the United States. Basically, they looked at life expectancy gain over the 20th century by decade blocks, and I won't go into detail. Obviously, it's a lot of the gain was in the earliest part of the 20th century with kids in the United States, 5 or 6 years life gained. The only relevance of this slide is the fact that you get some gain in that middle block, which is the 1940 to 1960 period. That's vaccines being introduced. But the important thing is to realise before 1940, you haven't got antibiotics. You haven't got vaccines, but you've got all the child gain. By the way, I like that right-hand one after 1960, which is where I've got modern medicine coming in, paediatrics coming a role, so there's a role there. But the biggest gainers there are the elderly, like me, who are gain increasingly from good healthcare delivery. No argument against that. But if you want to make a major social difference, and you ignore that left-hand side of the reason, which is where the social gains are to be made, we can do all the technology down the right-hand side we like, but you're talking about a year and a half of life gain, not the big substantive gains that you and I... So this stuff does matter if we're going to make serious differences in health outcomes. Like any good paediatrician, I'm going to drop back to children. They're cute, we like working with them. But it's relevant to this topic because the early years is when you and I shaped the brains that you and I have inherited through most of our lives. This is not an argument for determinism. This is not an argument to say that I don't have plasticity now. I've read the studies and know that I have great billions of neurons to play with should I have a stroke, and I thank God for those things. But I do know from the evidence that we are born with about 25% of our adult brain architecture already developed by the time you're born. By the time you're 3, 80% of your architecture is already shaped. 80%. And the other stuff's good, and as I love playing with the billions I've still got to play with, but if I'm going to make a difference to people's outcomes, I need to understand that the neural architecture, which shapes your neuroendocrine pathways and your risks, is important, and we have to be cognizant of it. It's not uniform, there are critical periods, and it's all about this inputs that we get as people when we're growing up. This is normal child rearing. It's not Mozart being played to pregnant women. It's just care, talking, feeding, the kind of things that you and I understand. But children who don't get that have serious impacts. One example, there's a seminal piece of work done in the 90s by Hart and Risley, which basically looked at how many words do you hear over your years of life. And there's a clear social gradient there. That the people who are on professional status speak more to their kids than the people who are in the welfare recipients. Interestingly, when you break it down by encouraging words and discouraging words, there's an inverse to that picture. This is setting the stage for the kind of neurodevelopment this kid's going to have for the rest of their lives. This is setting the stage for how they react to their children in the future. And as a good paediatrician, I like to focus on the hard edge stuff of medicine. When we do analysis of children who are born deaf, and we've identified their deafness, we put on a hearing aid, or we give them a cochlear transplant, whatever. Thank God there are people who do research about what happens when you do all that stuff. Well, they've been following up these kids around the world. And at 5, yes, the age of detection plays a role. It's about 12% of the variance of vocabulary. But 35% of the variance, and in another study in the US, 58% of the variance, is whether your parents speak to you and how they speak to you. So you could have this situation where you've got the kid's hearing deficit detected, you put the cochlear transplant put in, you've got great medicine, and they have crappy vocabulary, bad language, unable to function, unable to get through school, unable to get a job. Not because we didn't have good medicine, but because the family context didn't build on what was built. The other part that's important to understand is that negative experiences, if you have early, have profound impacts which last through your whole life. This is a seminal piece of work by a guy called Felitti, and it's worth, if you've never seen it, to revisit those studies, because these people have been tracking what happens to the number of adverse child experiences you have in your early years with your future risks of life. And when they're talking about adverse child experiences, they're talking about abuse, neglect, but interestingly, somebody in the house who abuses mother, somebody has a mental illness, somebody goes to jail, somebody has a substance abuse. These are not uncommon situations. These experiences have a dose-dependent relationship, strong dose-dependent relationship with whether or not you're going to pick up smoking, whether you're going to have early sexual activity, whether you're going to be pregnant, whether you're going to end up trying to commit suicide as a teenager. And this group has been publishing for now 30 years almost, and they're now showing that right up into the 70s, you can still detect that effect of the adverse childhood experiences. This is not trying to say, oh, look, you can forgive everything that's going on. If you want to understand why some of these people do go on to have obesity, alcoholism, and they're intractable patients, you're dealing with somebody who's already built up a risk which is hard to modify. This was a second piece of work, just thinking laterally, because beyond health, we've been involved in juvenile justice a lot in the Northern Territory where I've been working. In Sydney, late 90s, there was a superb piece of work published for Australian youth. Basically, what are the determinants of young people's offending and then becoming socially problematic, not failing school, failing to get jobs? Well, for Australian young people, 58% of the variance is whether you're neglected before 3. 58%. That's taking into account all those other crowded dwellings, all the other factors we say are social factors as well around poverty. 58% of the neglect of your offending risk happens before you're 3. And we wait till they become offenders and then have better juvenile programs, and surprise, surprise, we increase the amount of funding and the number of people still go to jail doesn't diminish. Because we're not dealing with the real risk factors. Medicine says you identify what the causes are and address them. Okay, this piece of work was done by a woman called Emily Werner. She did it in 1955. She took the whole cohort of one Hawaiian island and followed them for 30 years. Now, that's obsessive. But she published some amazing work. Out of that 700 kids, 200 had very, very bad early starts. Prematurity, social disadvantage, the whole risk factors. What she was surprised with, a third of those kids did really well. They lived well, loved well, were nice people. And she asked the question, how the hell do they do that? And she had the opportunity for having tracked every child to go back and find out. And for virtually all the risk factors, including the biological risk factors, the caregiving environment was a predictor of whether or not they broke out of that cycle. So and by the way, that wasn't just necessarily the mother, because some of these kids had mothers who could never provide the care that was needed, and they found alternates who provided that care for them. It was the caregiver that shaped that child's risk way back at the early years. It's not just about poverty. There's a superb piece of work in Canada which shows that if you correct for poverty, 10% of the risk of child's behavioural, developmental problems, which links to their social origins, can only be attributed to the poverty itself. Even if you account for poverty and all its associated factors, that's less than 20% of the variance for those factors. The other 80% is caregiver. As summed up by Alan in a really brilliant report from the United Kingdom, it's what the parents do, not who they are. This is not a plea for maintaining poverty and disadvantage and racism. This is saying that while we're trying to get these larger social forces in train, we can make a difference to these kids so that they don't end up being young people who start to have sex early, smoke, or take drugs, or go to jail, or try to commit suicide. We can make that difference if we identify what the real drivers are. This is where the real science happens. And in fact, it's fascinating. I'm not going to bore you on Saturday morning with a ream of science. That's not what this is about. If any of you are interested in these references, you can contact me or the AMA. I'll provide you. There's some really good science about this stuff. Last December, the Proceedings National Academy of Sciences published a superb supplement. Basically, they added up what was going on around the world in understanding the social determinants of health as a biological process. And this is arcane science. This goes from Drosophila to rats to monkeys to people, and epidemiology included. Basically, it's about understanding how the social adversity gets under your skin, from the street, from the house, into your physiology, and then down to methylating your genes. So we can actually tell you which genes get methylated and what risks they create for the rest of your life. All that's cute, but that doesn't change the fact the outcomes are still terrible, and we end up ignoring that science to our peril. Basically, that early years environment, the stimulus these kids get, shapes the way the cortex evolves. Well, your self-control is derived from the way that your parents cared for you early in your life. It's nice to tell the teenager, back up and get on with it, and face life's realities. Their cortical structures, which help determine their capacity to do that, have been shaped. This is not, again, an argument for determinism and giving up on these young people. I love the adolescent services that are running there. I want to reduce the number of young people that require adolescent health services or juvenile justice services or adults who need your services for some chronic alcoholism. This is, again, another one of the studies, and I won't go into them. Don't even try to read them. There's lots of detail in them. It's about the early years origins of many of those chronic diseases that you're dealing with in adults, and they can identify the immunology processes that drive those processes in the young baby. So your environment shifts your neurological interpretation environment. It actually changes the endocrine environment and methylates specific genes. By that, I mean that you actually have a lifetime inherited risk which you stay with. The evidence for unmethylation is not very strong. This was a different set of studies by a different group looking at twins in the same womb. Children who express different degrees of stress, can be because the blood supply is different. They respond to that stress by switching off certain genes and switching on certain genes. So they virtually develop their insulin resistance in utero as they're becoming stressed. And it's a physiological response. It's there because it was actually an environmental ecological survival tool. Okay, all that's very depressing and it's true and science is boring on Sunday morning. What can you do about it? Well, actually, you have to start focusing on prevention because the evidence on impact once you've got that acquired life risk, be it insulin resistance or your predisposition towards alcoholism or gambling or anything else, our interventions are pretty poor. Take something like obesity. I know for the last 20 years, I and my colleagues have been interested about preventing obesity. Well, there are more programs than there are obesity reduction going on. We just love having an effort rather than actually getting a result. I'm proud that we have effort. I'd like to get some results on the board. That means identify what are the drivers. This is a superb piece of work done in NT by Sydney University. They looked at the 2 remote communities in Northern Territory and did a case file audit for kids' use of services. Well, these children have more clinical contact than any child in Australia, a mean of 28 visits in a year in their first year of life. And these children, 40% of them are admitted in their first year of life for serious illnesses. So services alone are not going to redress that imbalance. You need good nutrition, good nurturing. Not rocket science. Getting it happening is hard in environments which are complicated. Interestingly, there are initiatives that can turn that around, and I'll just focus on the ones in the two in the blue. The only one that I might just mention on the left, getting a mother through high school, through 12 years of high school, has more impact on children's growth and development than any intervention you and I can muster, any program we can do in health. I'm talking mothers smoking, I'm talking birth weights. Antenatal care doesn't compare with getting a girl through 12 years of high school. Yet we still focus on just the health program. Those programs in that blue, there's a nurse family sustained nurse home visiting program. I won't go into detail. If you're interested, I can provide you that detail. This is a study which has had 3 randomised controlled trials, 20-year follow-up. These kids have benefits. This is the only randomised controlled trial evidence of child abuse prevention. Everybody else hopes that they might reduce prevention. These programs have shown they can reduce child abuse. They have effects into teenage years. They have effects for the mothers. And this is being replicated slowly in Australia. It fascinates me how hard it is to get randomised controlled trial data into practice compared to people's wish lists. This is another study, ABC-Darian, randomised controlled trial times 5. Basically, and the interest in this slide is, don't worry about it, it's an early years intervention program. The only thing that's relevant from this slide is this is basically the number of kids who have normal IQ above 80 in their first 4 years of life. These are normal children when they start in a disadvantaged community in North Carolina. The kids in red had the program, no great surprise there. What worries me is that yellow bar. These are normal kids with normal IQ when they start. Within their 4 years, 45% have normal IQ left at the end of 4 years. These are normal children, nothing else is going on with them other than living in an impoverished environment. There's another study, and you've probably heard about this one, Perry Preschool. That's a 40-year randomised controlled follow-up. 40-year, 4 decades. It has effects continue and continue and continue. Cost-benefit analysis has been done. This is amongst the few programs in health which have a very strong positive cost-benefit ratio, and they range from 17 to 1 now for Perry, right down to about 4 to 5 to 1 for some of the other ones. Good stuff, because accountants love it, treasuries love this kind of program. You invest in it and you can actually see measured savings, unlike most of what else we do in health. The real problem here is that, I'll just go on. One of the advantages of this process is the fact that these interventions differentially advantage the kids who are disadvantaged. There are almost nothing else in health. I can show you whether it's eat better, exercise more, lay your baby on the side. The advantages are differentially to the people who've got least risk. So we actually increase the benefit for the people who are well off in almost every health intervention. These 4 or 5 interventions actually have virtually no benefit for you and me, because your kids are already doing well, and have huge benefit for the disadvantaged, thus actually closing the gap rather than widening the gap, which is like much else what we do. The other side of this is those mothers who are playing Mozart to their babies and are going to go intensive early childhood development to get their kid from being just a bright kid to a Nobel Prize winner, wasting their money. Okay, if you want more, there's we did a series of papers last year through Menzies which detail the literature on this. If you ever want to, you can get in contact with me and I'll flick you the electronic connects for that. Despite all this data, despite all this recognition of the importance of social determinants, everybody keeps doing what we've always done, which is care for the individual who's got a problem right in front of us right now. Despite the lack of efficacy, we continue to do what we're doing. And in fact, as Alan said, the real problem for almost all our developed countries is we actually investing our dollars, continue to invest our dollars when you've got the problem, when it's least tractable, and when the results on efficacy are the least. Now, as I said, I'm a 60-year-old. I'm glad people are going to take care of me when I have my chest pain or my stroke. That's all wonderful stuff. But if as a social paediatrician looking at trying to get the best value for the buck in Australia, and particularly hearing how hard it is to invest in health, we better be doing something about where we can make the real changes. Your president last December in your magazine commented that if you want to close the gap in Northern Territory, if you're not doing early years, you're never going to be able to do it. You know, we believe that if you just keep reinvesting more health dollars. Okay, the real issue for us is not about keeping to do what we're doing in the past. You know that now that social determinants is not just about poor people's health, it's your health and my health. The way that those social determinants transfer into your physiology is through your early years. The kids who have very bad environments, this is now transferred from their experiences into their physiology and into their genes. and they're going to stay that way for the rest of their life. And they're your patients who have lifetime risk. That's fine. They merit care, and they merit your best attention. But if we're going to make a health system that goes beyond that, we have to provide address to what are the real drivers and address the programs that actually could deliver outcomes. The real challenge for you and me is whether we're going to continue to do what we've done in the past, which is wait till people have a problem, try to invest more money, start yet another program. Because you heard the ministers talking about, we're running out of money to do this. And at some stage, the punters are going to ask, is this 30% of the 40% of state budget good investment? Or actually, are we going to do this, what doctors should be doing is addressing the real determinants, which are the early years determinants of social determinants. Thank you.
Thank you to our speakers. Just to let you know, we started a little bit late, so we're going to run the session until 10:45, which will give a chance for a couple more questions than otherwise you might have. So we'll just go through some of the questions now. Is this working? Yep. Okay. The first question, I think, was probably for Dr. Klein, and it's how can we push governments to recognise that they have the responsibility to legislate in those areas that have the greatest impact on public health? Therefore, acknowledging that it has to embrace being a nanny state where nanny isn't pejorative, but actually describes a caring or pastoral kind of role.
Oh, that's a tough one to start with. I think there are many arguments for rethinking our investment strategies. They're moral arguments, they're evidence-based health arguments, they're economic arguments, and I think the ones that often have the best effect with government are the economic arguments. And I think, as Victor was suggesting, there are a huge cost benefits in rethinking the way we do invest, and it's probably a responsibility we all need to take more strongly to be able to demonstrate why a shift in resources to the early years, a shift in resources to address those deeper structural drivers of disadvantage at a locational level are going to have more positive impacts that are going to reduce crime, they're going to reduce rates of educational failure, they're going to make society more productive, there'll be more taxpayers. I'm not sure if I've really answered the question well because it's a little bit too it's a bit too hard for me, but it's something that I think really needs to be embraced by all portfolios across government, not just those ones that are driving for social justice, but it's a challenge. It's a challenge.
Thanks. I think person also to comment.
I just want to add a little bit to that. One of the things I didn't mention when I was talking about the slides about those programs that work is there's actually very good randomised controlled trial data which shows that programs like those ones that are there don't have the same effect. It's a little bit like this program works and the others don't. And in fact, it's fascinating how many few people want to confront that with government. The relevance of that to what Mark was just saying was that we've been promising government lots of things around early years for 2 decades in Australia. In the United Kingdom 2 years ago, the Audit Commission reviewed the early years investment. They found that they'd spent £11 billion on early years intervention with not one detectable health gain. In fact, 2 parameters got worse, but nothing else had changed. And they didn't poo-poo early years intervention. They just simply said, we actually identified 3 programs that work. Why don't you generalise the ones that work and dump the rest? Treasuries are actually very open to the idea of doing stuff that's good for people as long as you can show them that you deliver. Because one of the things I've met in governments is, like, for instance, I've seen governments told, look, do our program and we'll reduce obesity. Well, if it doesn't reduce obesity, who pays the penalty other than the taxpayer who has to yet fund more programs? So do what works rather than just what we hope will work.
Thank you. The next question, I guess, is for anyone on the panel. One of the main aims of Medicare Locals is to address service gaps or disadvantaged groups. In your experience, are they involved in these projects that are worthwhile? And do you see that they're likely to make a difference? I guess they're talking about Medicare Local projects. Maybe Mark. Yeah.
From a a very limited experience in Geelong. No, they're not involved, and no, I'm not confident they'll make a difference. I don't think that the people that they have on there are probably the right people, and their focus is on, at the moment, the medical record, shared electronic medical record, and after-hours services. That's what they're funded to do, and they seem to be building a nice little bureaucracy of people that are running all sorts of little programs, but not any of the sort of things we're talking about today. And I don't think that they actually have the understanding of the problems to make a contribution, at least in their current, in their current form. Personal view.
Thank you. Next question is, maybe Dr. Klein might be able to answer this one. Should we quarantine parenting payments and other welfare payments with recipients appropriately to access health care, protect kids and send them to school?
That's obviously been a fairly sort of contentious issue. I think that incentive-based approaches have a better effect because they actually drive change in the way in which parents and families behave over the longer term. I'm not sort of familiar with the evidence of how well the quarantining of payments has worked in the Northern Territory. I don't know if you are, Victor. I guess my problem with it is that it is contrary to the whole sort of ethos of engagement and community participation. And if we believe that actually engaging people to be empowered about the decisions that they make is really going to change health outcomes, I think it's a bit of a mixed message to then go ahead and quarantine their incomes.
Thanks very much. Okay. Next question is for Professor Nosser. Doesn't epigenetic effects of disadvantage mean that disadvantage is inherited?
Is what?
Inherited.
Well, no, epigenetics means that your environmental exposure in your early years takes your genetic load and then fixes it for the rest of your life. So it's actually not about inheritance of that risk. It's about taking whatever your family's genetic attributions were. You don't pass that generation unless you have germline transformation. So most of those transformations are not in your germline. Epigenetics means that your genes can get switched on and off across your body. And so what it's saying is that the experience of life that the baby's getting is switching off certain genes in their brain and switching on others. And it's not just their brain, it's this physiology. It's predisposing them towards being insulin resistant. We tend to see insulin resistance as a disease, which it is in our society. But you need to understand why the human race exhibits such a tendency towards insulin resistance. There's been some really nice studies which show that if you have famine, the people who are healthy die first, and the people who are insulin resistant survive. The reason we're insulin resistant is because it's a survival trait for feast and famine environments. And we, in our environment, unfortunately, start off with children who may be doing it tough, switch into, and that can be tough being in utero blood exposure, but difficulties with circulation. So the child interprets that being as a future life risk. But the trouble is, once you commit yourself to methylating certain genes, that's where you're stuck for the rest of your life. And if you then go on into a life of McDonald's and TV, then you're going to have insulin resistance going on to diabetes and obesity.
There's a supplementary question that I think is slightly related to this, and there was a question about the idea of resilience and why some people with a lot of social disadvantage, some migrant groups, for instance, seem to do quite well and others don't.
I think that issue of resilience, there is a group of players who believe that resilience is something you inherit. It's like from God, you just get a dollop of it. I suspect from Emmeline Werner's work that resilience is a product of lucking out and having somebody who gave you a normal first 3 years, whether it's with your mother or not. I mean, these kids that third of 200 kids who did well were children who either had a caregiver who took care of them, or, I mean, in fact, it's fascinating to read her books on the analysis of these kids. Some of them she said there were several trays. There were individual trays, kids who were likeable. So if you're likeable and, you're cute and you can get on and find caregivers wherever you are. And these kids actually went on, and as one teacher would be shifted off, they would go off and sort of, congratulations, you're my new mother now for the next few years. And so they would actually have caregivers who were stable, even if their own primary caregiver wasn't able to give them a meaningful environment.
I'll just also add, there's some new research that's suggesting that in terms of response to trauma, for instance, in childhood, that some interventions work well with people who happen to have a genetic loading that allows them to respond to some interventions and others don't, which might explain the treatment resistance for good treatments for PTSD, for example, in psychiatry. So that's just another refinement of this whole idea of what kind of genetic loading you have in terms of responding to environmental or psychological type treatments.
A few years ago, there was a seminal piece of work by a group between Dunedin and Caspi in Europe, basically showing that there is a particular gene variant which predisposes you to being likely to be in jail for serious violent offending, like sociopathic offending. And at the time, I remember thinking, oh my God, a gene for homicidal maniacs. They'll find these people and, preemptively treat them. And I loved it when I spoke to the group. They said you need to understand that 30% of the population has this gene. And two, only the kids who were basically abused as children ended up in that cohort. So if you have a child who's abused who has that gene, they are very likely to end up being in jail for serious, serious offences. And so rather than preemptively offending them, and I loved it because there's this geneticist who's saying to me, okay, it's over to you guys, the paediatricians, and now prevent them from being abused, which is exactly the real game.
Thanks. Next question. The Medicare item number for early child review seems to focus on classical biomedical measures. Is that a misplaced concept or poorly designed idea?
I have a whole lot of views about this medical review. It's a great industry. It has no science behind it. Zero. I mean, my argument is very simple to people. Okay, I don't mind all the proponents. Just tell me which child health outcome will improve, and there's a deadly silence from the players who are proponents of this stuff. It's an activity. We'll do lots of good stuff. My argument is just simply tell me what child parameter will improve. And there's lots of coulds and shoulds, but no silence. When it comes to contract times, there's lots of silence.
Thanks.
Ambition is wonderful as long as you can substantiate it and you don't use other people's money. Whereas here, they're using taxpayers' money to do an activity, which probably could help. But Christ, if somebody gave me $100 million and something I could probably do, I'd be worried about a taxpayer system that throws
talking about cost effectiveness. Another question is about the issues of health literacy and accessing transport and services in disadvantaged areas. How is the increased reporting on health services that's meant to give patients more choice in choosing what hospital, etc., they're going to go to, going to benefit them? So the things like the hospital report cards and the websites regarding outcomes. So the idea is giving patients more choice. Is that actually going to help in these sorts of circumstances?
No, I don't think it's going to make any difference at all, to be honest. The problem is there's not enough public hospital operating lists. There's not enough outpatient lists for the need for the proportion of the community that's reliant on the public health system. I mean, in our area, we're often sending patients from Geelong to Melbourne or Warrnambool or Ballarat to get operations because they can't be done locally. It's not that the patients are actually driving. They're not asking to go to a particular place. They're just asking to go anywhere that they can. And I don't think the people that I'm talking about from an area like Corinal Lane would be making decisions based on hospital report cards. Maybe we would be, because we would be interested in going to hospitals that had lower infection rates or, better results from a range of things. But the patients in Corinal Lane just want their operation. They'll go wherever we send them, wherever we can get it done.
Thanks. Last question for today is one about socioeconomic disadvantage. Isn't the answer to socioeconomic disadvantage to be found in resource redistribution aimed at diminishing relative disadvantage? Anyone on the panel would like to comment on that?
Well, I might have a start at that. I mean, if you have a look at studies like Richard Wilkinson's recent work. I'm just trying to recall what it was called. The something about. It was basically a work that went back to the question of the income gradient, and it showed against pretty much any social indicator, including a raft of health indicators, that Western democracies that had more equitable redistributive regimes did better on every indicator that that you could measure. So obviously that's not a sort of a vulgar argument, to, sort of levelling argument to just focus only on redistribution and not lose sight of the need to produce wealth. But it is a very strong case that those countries that, particularly the Scandinavian social democracies, beat the more inequitable liberal democracies by a pretty strong measure on any of the indicators that were assessed.
Thanks.
I think the argument about linking a whole range of health outcomes and life outcomes with social distribution is clear. The trouble is that I've never seen in my life, in the last 45 years, any appetite for any of that in Australia or United States or in England. And that's why, literally, what I'm talking about is we can make program differences to children's lives even while the state continues to be unfair. And I actually think that the structures are unfair, but the point is that's not going to change in my lifetime. In the meantime, we can make a difference to these kids' outcomes and improve their social outcomes.
Thank you very much. Would you please thank all the speakers again, Dr. Klein, Dr. Kennedy and Professor Nosser.
Thank you very much. My thanks to each of the speakers and advisors. A presentation of a gift for each of you. Remind the delegates if you could ensure that you check out by 11 p.m. if you can. I propose that I'll now adjourn the conference and we'll resume at 11:10, at which time we'll be in hands of the returning officer. Conference adjourned.
I'll give you.